It's my pleasure to speak to you today in the next 10 minutes. I just want to give you a brief overview about long COVID. There's a lot to consider here, and I think the take-home message is there are things that have been done, are being done, and can be done to improve the outcome of the patient. So there are three different sets of symptoms that are to be considered, but I will address mostly just the brain fog and the headache that occurs with these patients. I'm Professor Emeritus at the University of Illinois, Chicago. I'm Medical Director for a Physician-Assisted Training Program in River Forest, Illinois. I work with Fern, and hopefully most of these lectures will be available on our YouTube channel at Fern.org. Our educational objectives is really just to talk about how we address these pathologies in patients with long COVID. And what about the pandemic and long COVID? What is it? Long COVID is basically long-term effects that occur as a result of the acute infection. And when we consider it, the WHO has said these are unexplained symptoms that begin within 3 months of the acute infection and persist for at least 2 months. That's the take-home point. And we know that probably almost 2/3 of patients will experience some cognitive complaint as a result of the COVID. And if you consider that up to 2% of all COVID-19 survivors have some symptomatology, that's millions of patients around the world. So what's the pathophysiology? In the acute infection, remember, the virus is neurotropic. It goes to nerves everywhere in every organ of your body, and it also goes into the endothelium of your microvasculature, causing damage to virtually every organ. So what about the brain fog and headache? What is the pathophysiology? It's neuroinflammatory. It disrupts our normal neurotransmitter signaling. It causes a compromise in the blood-brain barrier that causes problems with cognition. And in fact, there's microglial activation, key biomarkers such as nerve growth factor change. So there's a lot going on here. With regard to the inflammation, there's sustained immune activation and pro-inflammatory cytokines that cause a prolonged inflammatory state. So what long COVID pathologies have been demonstrated? And this perhaps is the most important thing I want to show you, because when you bring up long COVID, people think it's such a somatization of not feeling well generally, but that's not exactly the case. There are a few things that have been proven. The spike protein from the virus has been shown to be sustained in the bone marrow of the skull, and that triggers chronic inflammation. And as we said, there are structural brain changes that are ongoing that have been demonstrated. So what are these anatomical changes? I'll just show you two studies. In one mice model, the respiratory COVID virus caused a loss of oligodendrocytes and myelinated axons, so your nerves do not work as well. This is perhaps for me the most interesting study. They have a UK biobank of patients who had an MRI before and after having had COVID because they were part of a different study. And those people who had COVID had a reduction in their gray matter thickness, they had increased markers of tissue damage, and their global brain size diminished as a result of having COVID. And these are compared to patients who had dual MRIs and never had COVID. And what you see in these curves, you can just see there's a separation in the amount of gray matter and the amount of tissue damage, those with and without COVID. And also from this study, you can see the separation in the graph that there's a greater task completion time in those patients who have had COVID. So this study demonstrates changes in the brain and changes in cognitive capability. So when patients say they have brain fog, they probably do have brain fog. Another study really looked at thousands of COVID cases with controls, and they basically demonstrated a decrease in hippocampus volume. We know that as your hippocampus becomes smaller, your ability to have effective cognition is diminished. And we know that with more severe COVID-19 early on, there was greater atrophy in the hippocampus. So there's a lot going on in many of the brain regions. Now, what about physiological changes? We note that there's episodic memory, attention, working memory, processing speed, verbal fluency changes that are seen in all of these patients. And the question is it because there's something going on in their brain, or do they just not feel well? Well, it turns out that there is worse cognitive performance in long COVID patients. Those who have structural changes, again, have some worsening in their cognition. And then you say, well, wait a minute, is it physiological? In fact, there is noted both hypermetabolism and hypometabolism in different parts of the brain that occurs for up to 6 months after infection, and fortunately, that resolves by 12 months. Those who are older have more severe neurological symptoms during the acute phase, and worse disease severity have more of these metabolic changes demonstrated on PET scan. So we know there are structural changes, we know that there are functional changes, and we know that the patients have symptoms. So one thing I just wanted to point out, this virus is very unusual, and the rates of POTS, the postural orthostatic tachycardia syndrome, is quite high in patients who have had COVID-19. And in fact, the rates are high, and up to 14% of post-COVID patients have transiently developed POTS, which is not insignificant. And I only point that out because if they come into the ED and you didn't know that, you might not be able to figure out why they're getting so tachycardic, or they complain of that. So what is an action plan? Generally, here's what you need to figure out. Treat the patients who have this cognitive dysfunction like someone with a concussion, and figure out how you can gradually increase their ability to do cognitive tasks in a way that doesn't give them headache or to make them feel poorly. In other words, whatever they can do without feeling badly, have them do, and hopefully over time, as those PET scan physiological changes improve, their ability to return back to normal cognition will happen. So there are lifestyle changes here. None of these are a surprise, but I will tell you this, a patient may not think about these, and so you as a physician can tell them these are things you can do to improve your skill set of your cognitive needs post-COVID. I just want to point out that there are other meds that are available. Neurontin and Lyrica, gabapentin and pregabalin, both can be used for nerves that are dysfunctional. You can also use amitriptyline and nortriptyline. These TCAs have been proven to improve non-functional or dysfunctional nerve functioning. There are other medications such as low-dose naltrexone. SSRIs have been implemented, and aripiprazole, Abilify, has also been suggested as a possible medication. The reason I point this out is because if they're on these medicines, at least you'll know why. Hopefully it's because they've been to a physician or a clinic that deals with long COVID. Also considered is metformin because it is anti-inflammatory and immunomodulatory in a way that may improve the chronic inflammation. Steroids, intranasal steroids, are suggested. I wish I had taken those. I got COVID early in California during this episode, and I really haven't been able to smell the same for 5 years. I wish I had taken the steroids, separate subject. So we know that there's pathology with COVID-19. We know with brain fog and headache that there is real brain structural changes and PET scan proven physiological changes that these at least will improve over time. The feeling of fatigue and weakness is really a separate story, but also there have been proven changes to mitochondria that demonstrate that. And we know that chronic inflammation is bad for all of our organs, and chronic inflammation is seen status post-COVID. Our long COVID patient care really should involve talking about lifestyle changes, and that's where a advanced practice provider, such as a physician assistant, could take more time to explain all of these, even in instances where you may not be able to. We've addressed some of the medications that are of use. They're listed on these 2 slides. And our recommendation, again, is to figure out how you can treat these concussion-like symptoms, how to treat the headache, and figure out a plan. And I think one of them involves our CGRP receptor antagonists, which are known to help migraines, which can exacerbate following COVID infection. And I think that regarding the fatigue and weakness, getting a physical trainer is an important thing, much like a life coach can help with the cognitive problems. We talked about developing lifestyle changes. One is an anti-inflammatory diet, which a gluten-free diet is anti-inflammatory. That might be a suggestion for anyone with long COVID symptoms. So in essence, I think if we could be more scientific and explain to the patient how they can be more scientific and tell the patient, don't judge your advancements or improvements every week, judge it every major holiday. If you go from New Year's to Valentine's Day and go all the way out into Memorial Day or Labor Day, and you can have them judge how they're doing over 2 or 3 month periods, they may have more faith that they're getting better if they measure it in longer windows. And I think that also gives the patients hope, which of course is what we're trying to do, is to give people who think they've got an illness that's never going to go away some hope so that they are proactive and can get better, both with your input but with their own lifestyle and medication changes. Thank you.